Now starting. All attendees are in listen-only mode.
Hello, everyone. My name is Karen Campbell, and I am the Assistant Director for the National Adult Protective Services Association. And I'm very happy to welcome you all to today's NAPSA Research to Practice Interest Group webinar. The Research to Practice Interest Group is comprised of researchers and practitioners who look at pertinent research questions in the field of adult protection, as well as how to apply research in the field. And thank you all for being here. Before introducing today's topic and speakers, I'm going to provide you all with some information regarding the technology that we're using for today's webinar. All attendees are automatically muted throughout the presentation. If you have any questions or comments, please feel free to enter those into the questions box that's located to the right of your screen in your control panel. Questions will be monitored throughout the presentation and read aloud at the end for the presenters to address. We are recording this webinar, and the recording will be posted to NAPSA's website likely early next week. A PDF of today's slides are uploaded in the handout section of that control panel to the right of your screen if you'd like to take a look at those. And then there are a couple of polls in this presentation today, so be on the lookout for those as we move through. So today we have a few presenters with us to discuss the role of APS workers in healthcare settings and innovation in practice. So the first is Dr. Farida Ijaz, who is a gerontologist with 30 years of experience in applied aging research and primary data collection. She received a PhD in social welfare administration from Case Western Reserve University in Cleveland in 1988, and currently she is a senior research scientist at the Center for Research and Education at the Benjamin Rose Institute on Aging. We also have Miriam Rose, who has been affiliated with the Benjamin Rose Institute on Aging since 2008 as a senior research analyst and research associate, and she is currently a member of the editorial board of the Gerontologist and became a GSA fellow in 2019. We also have Courtney Reynolds, who is a research analyst at the Benjamin Rose Institute on Aging and a licensed social worker. Deborah Billa, who has had an over 30-year career in aging program administration as a state regional director for long-term supports and services, an area agency on aging director, and now with the WellMed Charitable Foundation. Raymond Kirsch, who has been employed with the Texas Department of Family and Protective Services, Adult Protective Services for 19 years, and since 2014 has served as a liaison in a collaboration between WellMed Medical Management and APS. And then Catherine Bingle, who is an APS research specialist with the Adult Protective Services Division of the Texas Department of Family and Protective Services. So thank you so much to all of our presenters for being here with us today and to our audience. And without further delay, I will hand it over to you to get us started, Deborah.
Thank you, Karen. I am Deborah Billa. I'm with the WellMed Charitable Foundation, and my role here today is to give you a little bit of a background about our project that we're going to be talking about this afternoon. So this project was one of the projects funded through the Administration for Community Living, Administration on Aging, and one of the elder abuse prevention projects. We were originally funded in 2012, and the project, the evaluation piece of the project ran until 2016. The goal of these projects was to identify new approaches and intervention and prevention of elder abuse, neglect, and financial exploitation. National grantees included the Texas Department of Family and Protective Services and also the WellMed Charitable Foundation. Next slide, please. Our project collaborators on this project included the the Texas Department of Family and Protective Services, which was the lead grantee, and is also the state agency in Texas that is responsible for this statewide administration of the Adult Protective Service System. Also, the WellMed Charitable Foundation and WellMed Medical Management. WellMed Medical Management is a physician-led healthcare delivery system serving more than 500,000 Medicare-eligible seniors in Texas and Florida through the management of primary care clinics, multi-specialty clinics, and contracted medical services. We focus on a preventive coordinated care model that is a shift away from traditional acute and episodic care. The WellMed Charitable Foundation is an independent public foundation that focuses on serving seniors and their caregivers with a special emphasis on living well with chronic conditions. The Benjamin Rose Institute on Aging served as the local evaluator for the project. The Benjamin Rose Institute is located in Cleveland, Ohio, but does work across the country and is also a leader in the research field on issues impacting older people and their families. And also the Elder Justice Coalition, which not only provided federal insights into the project, but also helped us with the design and sustainability of our project as well. Next slide, please. Our intervention components included training clinicians in the WellMed clinics to identify, screen, and report abuse. Also to insert the use of the EASY tool, which is the Elder Abuse Suspicion Index, into the regular practice and the clinical protocols followed in all of the clinics. Embedding 2 APS specialists in WellMed medical management system to serve as resources to the clinicians. The APS workers documented the cases that were reported to APS. And also to distribute educational materials on abuse to patients and their caregivers, and reduce stress and burden for caregivers of patients with dementia. Next slide, please. The target population for the intervention was older patients of the WellMed primary care clinics. Also, the key characteristics of this population is that they're largely Medicare eligible, mainly Medicare Advantage enrollees, and some are dually eligible, and there's a large majority Hispanic population. The target population for prevention was the clinicians, which included all of the clinic staff in the primary care clinic. Next slide, please. The geographic location of the project included the then 5 regions where there were WellMed clinics located in Texas. That included San Antonio, which remains the headquarters for WellMed Medical Management, Austin, Corpus Christi, the Rio Grande Valley, and El Paso. And with that, I'm going to turn it over to Courtney Reynolds with the Benjamin Rose Institute.
Hi, everybody. So before I tell you a little bit about Benjamin Rose, we wanted to learn a little bit about you. So the first poll should be appearing on the screen shortly.
So the poll question is, what is your professional role? Researcher, physician or physician's assistant, social worker, nurse, or APS staff? And if none of those cover your role, please feel free to write into the chat and I'll read a few of those out. I'll leave this open for about 45 more seconds. And in order to vote, just press the little circle next to the option. All right, so I'm getting ready to close that poll. And then I'm gonna share those results. So it looks like 4% researchers, 21% social workers, 2% nurses, and 73% APS staff.
All right, great. Well, thank you. So that's exciting. So it sounds like we have a lot of practitioners. I was going to say in the room, but since we're not in a technical room, in the webinar. Well, we're excited to share more about this project with you and how it can apply to your own practice. But before we get to all of that, I'm going to tell you a little bit about the Benjamin Rose Institute on Aging, which is where I work. I work in the Center for Research and Education, and that the staff who acted as the local evaluator for this project, that's where we are based. We are an applied research institution, and we're one of the few nationally recognized research centers that's located within a service organization that serves older adults. And so you can see some of the services that our agency offers within the Center for Research and Education. As Debbie already mentioned, we're known for our research in the field of elder abuse, as well as caregiving and project evaluation, just to name a few areas. So I'd like to talk to you a little bit about the literature review that we conducted for this study. We started out by looking at elder abuse as a whole, and what the literature tells us is that the estimated prevalence of elder abuse in the United States is about 10%. In Texas, which is where this study took place, it is a universal mandatory reporting state, which means that if you see or suspect elder abuse, you are required to report it, and it doesn't matter what your professional background is. So that's in contrast to in Ohio, where we are, where the Benjamin Rose Institute is. We do not have universal mandatory reporting. Instead, mandatory reporting is based on your profession. So after that, we looked at the APS data, and the most recent NAMERS data gave us kind of some information about who the most common reporting sources are. And as you can see on your screen, social service professionals were the highest, most common reporting source, followed by medical or health professionals. And you can see, even though they are the most common reporting sources, the numbers are still quite low, that, it's just over 15% for each. So we wanted to look at why. So we started to examine what some of the barriers are, specifically to healthcare professionals, because that was the group that this study was targeting with the trainings and with the interventions that we were implementing. And what we found in the research is that overall, there's a general lack of comprehensive training for professionals, for healthcare professionals, to identify and report abuse. And that includes in their professional training in school, for example, medical school or social work school, nursing school, or after they've graduated, become professionals, become licensed, and are in the field. Additionally, there's a lot of confusion about reporting laws, and particularly around the idea of what constitutes suspicion. Mandated reporters are required to report when they think that abuse is happening, when they suspect it. And the law doesn't generally do a very good job of describing what suspicion means clearly. And so there's a lot of confusion on behalf of healthcare professionals about that. And then additionally, there are concerns in general by healthcare professionals about how reporting elder abuse could affect the patient, and the patient specifically in relation to the potential perpetrator, whether it could make abuse worse, or whether or not it could affect the patient-provider relationship, where the patient would maybe not feel as trusting of their healthcare provider as a result of the reporting. So then we looked at what innovative projects are going on to kind of address these barriers, and we found one in Sacramento, California. And it was a project that was reported on in a NAPSA report a few years ago. The report is called Doing More with Less. And in the project, APS partnered with a local hospital system to provide dedicated APS investigators to provide intensive case management services for up to 6 months to patients who are frequent users of the hospital system and emergency services, and who are at risk of neglect or self-neglect. And although the APS investigators were not co-located in the actual hospital, they met regularly with staff in teams to discuss cases and to decide what the next steps would be for interventions with the clients. So like the Sacramento project, our study examines a collaboration between APS and a healthcare system. And more specifically, we evaluated an investigator-initiated intervention that began with embedding 2 APS specialists into a healthcare system. And my colleagues are going to provide more detail in a little bit about exactly what that entailed. So these are the research questions that we looked at as part of the study. We wanted to know how many and what types of clinicians were trained by the APS specialists and project team members to identify and report abuse. We wanted to know what roles the APS specialists played during the course of the study. And we wanted to know if clinicians consulted the APS specialists on suspected abuse involving their patients and then did they make reports to APS. So now I'm going to talk a little bit about the trainings that were conducted with the healthcare clinicians at WellMed. There were 826 clinicians trained on elder abuse over a 1-year period. And they came from 63 primary care clinics across the 5 regions that Debbie pointed out a few minutes ago. And the training lasted about an hour, and it was an in-person training. And then the social workers in the group also received 2 additional trainings of 4 hours each. The trainings were approximately an hour long, as I mentioned, and there were 61 trainings in total conducted. And the content of those trainings included the things that you see on the screen. The attendees learned about the types of elder abuse. They learned how to identify and screen for abuse using a tool known as the Elder Abuse Suspicion Index, or the EASY. And then they also learned about reporting mechanisms and requirements. So this is a little bit of information on the screen about the people who attended the trainings. As you can see, there were about 532 people who we've included here, and their mean age was 40. And the youngest person in the training was 19, and the age went as high as 78. The majority of the people who attended were female, and about 2/3 were identified as white Hispanic. 44% said that they had some college but no degree. And you can see from the graph that the vast majority were medical assistants or patient service representatives, followed by physicians, physician assistants, nurse practitioners, nurses, and health coaches. And then social workers and case managers constituted only 3% of the trainees. So now I'm going to turn it over to my colleague, Miriam, who's going to tell you more about the APS specialists.
Hi, everyone. My name is Miriam Rose, and I'm going to tell the middle part of the story here about the APS specialists themselves and what did we mean by embedded. What it meant was they were actually housed at WellMed headquarters in San Antonio. They had their office there. They attended patient care coordination meetings. They were available by phone or email or in person whenever any of the clinicians, very broadly defined, had concerns about the possibility of abuse and needed to consult with them. Next slide. And just to give you a little idea of who they were, there were 2 starting out in about 2013, I believe. One was a woman, one was a man, who you'll hear from later. They both had a lot of experience, between 14 and 15 years as APS caseworkers. They were both at the highest level you could be for a caseworker. And they were, in the past, had worked in APS in a pretty responsible capacity with training new caseworkers, consulting on complicated cases, working on abandoned cases in rural areas. So They were really go-to staff members. And when WellMed was looking for some specialists to be housed there, these particular individuals were kind of at a good stopping point with their work in another area of Texas, and they were both interested in this work, and their regional director also thought they would be good at this job. So they were selected, and being one was a man and one was a woman, that gave them some flexibility depending if the clients might be more comfortable with one or the other. And for the person who spoke Spanish, that was a big plus in that area. Next slide. So after about 2 years of their work with WellMed, Dr. Ijaz, our principal investigator of the evaluation, conducted some phone interviews, one with each of them. The idea was this was a very qualitative kind of interview, just semi-structured, open-ended questions, which they received ahead of time, so they knew what she was going to ask. The questions covered, their role, and also any outstanding cases that kind of were, I don't know, stood out from others, perhaps. And then during the interview, there were 2 research assistants in the room with Dr. Ijaz. They didn't speak, but they were just there to listen. And the interviews were recorded and then transcribed verbatim. And so then later on, after that happened, the 2 research assistants then read through the transcripts and were identifying themes throughout the interviews. And then they did it separately, then together, then with me. I was a senior research analyst at that time. And then we all, as a team with Dr. Ijaz, reached consensus on those. Next slide. So I'm just going to focus on a couple findings that were, I think, most relevant to our audience today. One is how versatile these APS specialists were, because they had so many different roles at WellMed. You've heard about them as trainers and educators, and they were also consultants, and of course a resource. But I think what was also interesting was how they became a liaison between APS and WellMed, and also were advocating for the patient/clients. So they were making sure that nobody dropped the ball, that no one fell through the cracks. They kept on top of the cases to follow them if they were reported, to make sure someone was paying the necessary attention. So they were really doing a lot of different things at the same time, and are continuing. One is still continuing to fulfill that role. The other way they were very versatile was in the different populations that they had interacted with. So it wasn't just the clinicians, it was also the patients or clients, the family members of the patients and clients, other APS workers throughout the whole state of Texas might be talking to them. And then they had to kind of keep their ties with the community open at all times, because they were helping to make recommendations about services and referrals. So they were pretty busy people, and still are. But they were, very helpful in making recommendations and helping to make sure that people who were at risk of abuse were also part of their responsibility, because it wasn't only people who were reported to APS that they were concerned about, but people who might be reported because they were kind of headed in that direction. So some of the help they provided was to people who were patients but not reported to APS. Next slide. So as I said, they attended these patient care coordination meetings where clinicians would present a case of a client who they thought might need help. There was suspected abuse. So the APS specialist could give advice on how to proceed, whether a report was needed, or if there might be other ways to help this person until a consensus could be reached. And in addition to the meetings, as I said, they were also available by phone and email. But when it got to the point where it was decided a report needed to be made, then the APS specialist would encourage the clinician to do the reporting rather than saying, oh, well, you're an APS specialist, you can do it. But they really wanted to improve that relationship between APS and WellMed, and so that the clinicians would gradually feel more comfortable in reporting themselves, reporting the clients by themselves. And also they highly recommended that it be done by phone instead of online so that they could answer questions and have a conversation with the APS intake worker. Next slide. So one of the things that the APS specialist did, which really wasn't something we knew was going to happen, it wasn't part of the original plan, but it turned out to be quite a important source of data for us, was they took notes, starting with handwritten notes about the patients that they consulted with clinicians about. And they did this over a period of actually a little more than 30 months, about 2.5 years. And at some point, the written notes transformed into a table in Word with, columns and rows. And the specialist assigned a unique ID for each patient. There was really no identifying information other than their gender and age. But I'll tell you more about what else was in there. But really, it was de-identified information to the point where after the fact, they couldn't even link the people with their names anymore. And again, we did something similar with analyzing these data as we did with the semi-structured interviews, where we had the two research assistants by themselves and then together looking at categorizing and themes and things that we could somehow make this a little more quantitative. And then also consulted with me and with Dr. Ijaz until we reached consensus. And then we took this table from Word and put it in Excel, and that enabled us to actually analyze the data in a quantitative way with a program we use called SPSS. So next slide. So in addition to the very little bit of identification of the clients, we also had a list of allegations, the type of staff at WellMed who made the report, and so not their name, just were they a nurse, were they a social worker, physician, or whatever. If they had a history with APS prior to this report, and what methods that APS used to resolve their cases or to provide services or find services to refer them to. And that's where we spent like the bulk of our time trying to put things into categories, which was kind of difficult because there was so much detail in these notes. But you'll see later on, we kind of had to boil it down. But the data were extremely rich, and we don't know how we would have gotten this information any other way. It was invaluable. And now I'm going to turn it over to Dr. Ijaz.
Thank you, Miriam. Can everyone hear me?
Yeah.
Looks like it.
Yeah.
Okay, thank you. So I'm going to talk about the exciting findings from this project. We are very excited about it because it was such an innovation in practice, taking two APS specialists and putting them into a healthcare system. And as a result of the case consultations with the APS specialists, there were 529 patients that were reported to APS during the 30-month period when the APS specialists were collecting data on them. And even though we didn't track the prevalence of dementia amongst these patients, the APS specialist said that probably about half of the patients they consulted on had dementia. Another interesting finding was that about more than half of the patients never had a history with APS. So we feel this may have been the group that we helped the most because they may not have been identified as being suspected of being abused in any way. So this, not to say that the other 45% were not critical to our findings or the help that they received, but we think that this is unique that more than half were reported for the very first time. Next, please. So the majority of the reports to APS were made by the social workers. More than a third of the patients of the 529 were reported by social workers. And about 14% were reported as a result of the care coordination multidisciplinary team meetings. And an equal amount, 13% or so, were reported by nurses. What we found was that the 529 patients had a lot of suspected allegations. In fact, they had a total of 902 allegations. But when we broke it down, we saw it was just about a quarter, about 27% that had of patients that had multiple allegations, whereas the majority, almost 2/3, had just a single allegation. So about 75% had, 3/4 had a single allegation, but that one little group had multiple allegations, pointing to the fact that perhaps polyvictimization was going on in those cases. Next, please. When we broke down the allegations and looked into it further, we found that self-neglect was prevalent in 90% of the 529 cases. That's a huge number. Neglect by others was next, about 17%, and by others we mean providers who are like home care staff, relatives, friends, neighbors, spouses, partners, people like that. And around 10% of patients had issues related to physical abuse, sexual abuse, and exploitation, emotional abuse. So you can see that's almost around the same amount that of patients that had those sorts of allegations. And again, self-neglect predominant. It's predominant in our sample. Next slide, please. If we looked at the allegations, now we analyzed the data by patients, then we looked at the allegations. And the 902 allegations, of the 902 allegations, 69% related to self-neglect. So just to make this straight, 90% of the patients had at least one allegation of self-neglect. But if you just look at the 902 allegations as a pool, you would find that 2/3 involved self-neglect, followed by neglect by others, exploitation, and then there were physical abuse and emotional abuse. So this is how the allegations were broken up. And when we looked at it, how many allegations were validated or substantiated? If you look at it, 50% of all the allegations were substantiated. But if you just focus on self-neglect, 69% of the self-neglect cases were validated. So that is, that is very interesting. And if you see, we probably should have used the median in this slide rather than the mean, because I think the mean is skewed heavily by the 69% of self-neglect cases that were validated. Next, please. So where were the patients referred to? We were very interested in knowing what happened to the patients in terms of their reports. So what were the kinds of referrals they received? And if you can see, home health skilled care was by far the highest number of patients. 80 patients were referred to home health services. This was followed by about 79 cases, 79 patients who were reported to community resources, public assistance, transportation. One of the things I want to point out to you in this slide and in the previous slide was that sometimes that our totals don't add up to 100% is because some patients had multiple allegations and some patients got multiple service referrals. So this is just rank ordered. This slide is just showing you how we rank ordered the services that were most provided to the least provided. So the most referred to and the least referred to. Then there were some patients that, even though APS uses the least restrictive alternative, some patients had to be relocated from their own home and were moved to residential care settings like assisted living and nursing home. Some were also relocated with other family members or friends, or they had to relocate alone to live in a more secure place, like an independent living facility or a senior high-rise or a public housing unit where they had more supports in place. Another way of looking at our data, if you look at that golden bar which says family, friend support, and involvement, if you add these are how APS really worked with family members and friends to enhance the supportive network of their clients. So if you look at that golden bar with the family and friend support, and then you look at the green bar, which has client and or family assistance and education, this is where APS workers handed out brochures, information on services, or just gave them education on stress reduction. So either the family or the client received some sort of education. But if we combined the green bar, which has the family assistance and education, with the golden bar, which is on family and friend support and involvement, if we added that up, the 40 and the 49, it would become 89 patients who had some sort of a family involvement or that APS got them involved with, or they worked with the social worker at WellMed to help the family in many unique ways. So you can see it wasn't as if family members were just perpetrators. They were the people way up there trying to help and support an older individual. So there may have been some perpetrators, but there were other family members, those who were not perpetrators, were involved in trying to help the family out. But since our study pointed to the fact that 90% of the clients that were reported to APS had self-neglect, the role of the family member or a friend or a neighbor becomes even more important to try to help an older adult live successfully in the community. It also points out to the fact that self-neglect, perhaps there was this dementia going on in the person's life, in the patient's life, or the patient's spouse. Someone had dementia, or there were cognitive challenges that the patients were dealing with, and therefore getting other family members to join in and help the patient became perhaps even more important. Other types of services, if you look at other types of services, there were housing options discussed, the navy blue bar. We don't know if in these cases, in these 38 cases, whether the patient actually went and relocated to an assisted living or nursing home, because we didn't follow patients after the study ended. And that, we think, is something that should be done. If you provide services or you refer people to services, wait a couple months and go back and follow up with them to see where they are in their lives after, say, a couple months. Other types of services and supports, there was Medicaid, non-skilled long-term services and support, hospice, palliative care. We were also very interested in pest control, but you can see only 12 patients had pest control come in and clean their houses. So even though it was self-neglect, that didn't happen as much as we thought it might. Another interesting finding is that there were about 20 patients among the 529 whose alleged perpetrator had to be arrested, evicted from the house, and legal and law enforcement got involved. So 20 patients it became more of a criminal issue rather than a civil case in these 20 instances. Next slide, please. So we think that our APS specialists really helped to raise awareness of patients' social concerns beyond their healthcare needs. So this really gets into the social determinants of health, which is becoming a popular term today. And we think that in 2012, we were one of the innovators that went into and looked into this component of the social determinants of health. And in our case, it was reports to APS. Social workers made the most referrals. It's perhaps because they got more in-depth training. If you remember, they got 8 hours of extra training. So it could be due to that, or it could be that physicians and other clinicians said, hey, this is not part of my job to really do the actual reporting. Why don't you do it? So it could have been that other clinicians made social workers do the reporting. Another, like I've mentioned, this finding of 90% of our patients had self-neglect. This is much higher than what's been reported in even the NAMERS data. The most recent NAMERS data found that 61% of all the reports to APS nationally involved self-neglect, but we had 90%. This aligns more with what was happening in Texas at the time, where 82% of all their cases had an allegation of self-neglect. So perhaps it's Texas, perhaps it's because we were dealing with healthcare patients, and perhaps because once we train physicians to think of abuse not just as emotional and physical abuse, but to think of it as self-neglect, to enhance that understanding that self-neglect is also a type of abuse. Perhaps physicians started noticing patients who were coming to them who were dressed poorly, dressed inappropriately for the weather, who were unkempt, who hadn't taken a bath, who had a strong odor. Perhaps they became more attuned to that sort of understanding that this too is a type of abuse. And for that, because of their heightened awareness, we think that they were very successful in identifying such cases, and that Texas APS, for the large part, over 2/3 of those cases were validated as being actual cases of self-neglect. Next slide, please. So I want to make it clear that it wasn't a bed of roses from the beginning. There were many thorns along the way. Initially, both APS specialists as well as the healthcare staff mistrusted each other's roles. They didn't know why a state agency is walking into a healthcare facility and perhaps interfering in patient care. There was, some clinics refused to be involved in the study initially. They didn't want to be a part of it, and they felt it was encroaching their time. They didn't have enough time with patients, and this would be an added layer taking away from their clinical work. And they were also, some were frustrated that it took APS so long to tell them what the outcomes were. The state APS staff too initially were not very happy. They felt this would increase their caseload without a staffing increase. And in fact, 2 of their staff were taken away and moved into another setting. So there was some discontent initially. Next slide, please. Eventually, however, there came to be a wonderful understanding and a great relationship that evolved and emerged and crystallized as a result of this partnership, this unique partnership. It led to trust and understanding. Specialists had the advantage that they had access to APS data and could tell clinicians what was going on. There was a data use agreement between the healthcare system and APS. They could share data. And APS staff could call the doctors and the clinicians and the physicians and the social workers at WellMed and tell them what's going on with the case and how they could step in and help. So it became more of a collaboration and more of a method to try to fit the pieces and parts together to come up with a case plan that's holistic and comprehensive. The APS staff also had to train clinicians about the concept of client self-determination and autonomy. They had to make sure that physicians understood that just because they are a government agency doesn't mean they can clamp down on the client and force the client to accept services. They also had to explain that you can't put everybody into a nursing home just if a patient doesn't want to go. You cannot force them, and you have to give them least restrictive options. One interesting thing that came out of the study was, excuse me, some physicians and nurses and social workers started making house calls. Some made it with the APS staff, some made it on their own, and they really learned what the life of their patients were beyond the clinic. And this became even more clear for patients who had early stages of dementia, were struggling to live alone in the community or with an older spouse. Next slide, please. Some of our limitations in the study was that we did not document dementia systematically. We are doing that in an other grant, and we didn't use a randomized clinical trial approach where we had a control group and an experimental group. It was a preliminary study that really looked, a cross-sectional study that looked at the lives of patients and how APS and social work and a healthcare system could improve their quality of life of their patients. The strength of the study was that we think we did something really outside the box, and we were excited about this innovation in practice. Next slide, please. Patients received protective services that they may not have. They were safer, we felt, even though some had to be relocated. And the manner in which family relationships were enhanced was really amazing in this study. And I've mentioned that this was a very frequent thing that APS and the WellMed social workers work together on. Next slide, please. I'm going to turn it over now to Raymond Kirsch, who was one of the APS specialists who was placed in WellMed and continues, 8 years later, continues to be a staff member who is shared between WellMed Medical Management and APS and is housed in WellMed. Ray, I'm turning
Thank
it
you,
to you.
Farida. Thank you, Farida. A great example of this collaboration is a case study that involves two Hispanic brothers. One is 54 and has difficulty walking. He suffered from seizures and had cognitive issues since he was very young. And he's living with his brother, who's 64 years of age, who was wheelchair bound. He had an above the knee amputation. He suffered from COPD. He was insulin diabetic, and he also was battling liver cancer at this time. As Miriam had mentioned, with in our role as a liaison with APS, we have to attend what is called a PCC, or a patient care coordination meeting. And that's where the entire medical team within each clinic has a weekly meeting where they discuss their patients that they have concerns about. So it was during one of these meetings that the brother, the 54-year-old brother, was brought up, and the main concern was that he had repeatedly missed appointment after appointment, and they were concerned as far as what was going on in the home. We encouraged them to make an APS referral, which they did, and then we went over to check on the client. Next slide. So after the referral was made, we were able to determine what was going on in the home, and it was basically, as we found out, the reason why the brother wasn't going to the appointments was because of a lack of transportation. That was the basic issue. So that was something that we could easily assist with. But when we got into the home, the APS workers discovered that there were much bigger issues than just lack of transportation. There was a sliding glass door that someone had tried to break into the home, and they had broken the glass out of the sliding glass door. And so the clients were putting up boxes in front of the door to make it look like a solid structure. This was in February, and it was during a very cold winter snap that we had down here, and the house was freezing. And they only had they had sequestered themselves into like a little area that had been like a living room, and they had covered it in plastic, and they had one little tiny space heater in there, and the house was freezing. They didn't have a running water in the bathroom, as far as like the no working toilet. There were all sorts of issues in the home as far as what was going on. And then another issue was, as I mentioned, the older brother was wheelchair bound, and they had a metal ramp on the front of the house, and someone had stolen the metal ramp, I guess, to sell for when metals were going high. They had stolen the ramp off the front of their home, and so there was like 8-inch drop, so he couldn't get in and out of the home safely. And so one of the things that, like I said, we were challenged with was that the lack of transportation we were able to deal with easily by making a referral, but then we were trying to get assistance from family, and they had family that lived very close. The older brother had children, but they were all told us they were involved with their own families, and they didn't have time for them. And like I said, they had the broken door, lack of heat, and the plumbing issues. And so when we were talking to the older brother, who was the primary caregiver of the younger brother with the cognitive issues, he had made a promise to his mother. You know, we discussed different options, and he had made a deathbed promise to the mother on, that he would take care of him. He would never let him out of his sight, and we would discuss that, here he had cancer. He had all sorts of health issues of his own, and, that he needed to address. And so, there again, he had guilt, he had fear of that something was going to happen to his brother. And so we had to work really closely with him to get him to accept the involvement of APS and WellMed. And they had never thought in talking to him, he had never thought about seeking assistance. He didn't really know who to ask. So next slide, please. So when we discovered, of course, initially our first concern due to the cold was to go out and use our purchase client service funds to purchase the heaters and blankets. And also, it gets very hot down here. So there was the AC unit, the window unit had been stolen out of their home. So we were able to purchase that for them as well. Then we worked with the WellMed side, the social workers with WellMed, and they have a palliative program called Bridges, whereby the physicians and nurses will go into the home for individuals that have difficulty getting to their medical appointments. We immediately enrolled both of them on we have a transit system here in San Antonio that works with transporting the elderly and disabled, and we got them enrolled with that. We had the back door window fixed. WellMed had assisted with getting Meals on Wheels over to the home so that they could eat. We also worked on getting the residence cleaned up because there was a lot of clutter. And, with one being barely able to walk and the other in a wheelchair, it was, putting them at risk. We also worked with the brother on getting him to accept the younger brother going into an adult daycare that deals with people with cognitive issues. And that was a huge hurdle. There was crying involved, everything else. But, there again, I think with APS and WellMed working together, the WellMed social worker and us both, he grew to trust us and know that we were there to help and not to, just, put someone away. And as far as the ramp in the front, we were able to get a contractor over there who poured a cement ramp in the front of the house, so they could safely get in and out of the home without being scared. And arrangements were made for provider services, and there were numerous other house repairs that were made. But we got a plumber in there, got the toilet fixed. There were electrical issues in the home where if they plugged something in, the fuse would blow. We were fortunate that we all worked together to see what resources were out in the community to assist with them. So next slide, please. So the outcomes, we were able to improve the safety of his home and environment, and we also were able to put him in, or connect him rather, to different resources and services in the community. And we were able to make sure that they had access to medical care and were able to get in and out of the home safely. And we had full wraparound federal, state, and local services involved. And then in the end, working together, APS and WellMed working together, it was helped to increase their ability to live independently and to be self-sufficient for their own, with the key word being safe. Next slide.
Thank you, Ray.
Okay, thank you.
I can take over from me. So in terms of the sustainability of the project, WellMed incorporated, as you can see, Ray has been incorporated into the healthcare system. And the executive director, Carol Zernial, said that this partnership was so much of a culture change for their clinicians. It really opened the clinicians' eyes and ears to think outside the box and to think of their patients as people who had a life outside the healthcare system and had complicated lives whereby the social issues that they were facing, if the social workers could work together with adult protective services, like Ray said, they could improve the quality of life of so many of their patients. And one of the things that the executive director said was that if they would have helped only one patient, and Gray gave the example of only one case, but there were 529 cases that had stories behind them of the wonderful work and the collaboration that happened as a result of this project. So if you think of 529 cases, someday I have a dream to write stories of those that could be used, of course, anonymously, that could be used as, education and training for APS workers as to the critical role that they play, and even in collaboration with social workers outside of the APS system. So this, we think, was a huge contribution for us in the field. Next slide, please. The good news is that our collaboration was recognized in 2018 by NAPSA, and we won the collaboration award. So even though at times we felt initially that this project was too ambitious, we couldn't do it, we don't think anyone would be reported, how can we help people? We felt like we were slipping, but at the end, we came out, we feel very successful, and it's been a great collaboration. Next slide, please. Next steps. In 2016, we applied for an Elder Justice Innovation Grant, the same partners, Benjamin Rose, Texas APS, WellMed, and we focused on self-neglect because we felt what is going on with the patients. We had such a high percentage of people with self-neglect. We wanted to develop interventions to prevent self-neglect among people who had risk factors for self-neglect, like people with dementia that we mentioned, people who had very high depression levels, who lived alone, were socially isolated, didn't have family members around. So we felt we needed to look at that group and develop interventions, a home-based assessment and an intervention and a case management plan that would follow patients for at least 4 months. So we've just finished all the data collection and we've started analyzing the data now. And by 2021, we hope to be finished with all our data analysis and present. We have something we're going to present at NAPSA this year from the initial findings from our study. In 2018, we partnered with Oklahoma to enhance their self-neglect practice based on our prior work in Texas. The difference is that this time it's not healthcare patients, that's our target population, but our target population is really clients who have been reported to APS with an allegation of self-neglect. And again, we want to enhance the services we are providing to such clients and follow them by developing a case management plan and following them over time, over a 4-month period. In these two studies on this slide, we are using randomized clinical trial approach whereby some people get usual care, whatever was the standard of practice, and then the enhanced intervention, which includes assessment in the home and a case plan to follow them over 4 months. Obviously, with the pandemic right now, it's put a damper on our assessment that was going to begin with that in Oklahoma, where we were going to go into a client's home to do the evaluation in person. We have to change that practice to doing it over the phone. This is going to be, we know, a challenge. And since we can't walk into the home right now, Oklahoma, only in emergency situations are workers going into somebody's home. So we are changing our protocols, and we will, by next year, we will know how that works. And we hope to share more about both of these grants with you in the future. Next, please. Can you bring up that poll, second poll, please?
Absolutely. So this poll question is, do you think it would be feasible for APS to either embed or partner with a local healthcare organization? The options are yes, no, or don't know / unsure. And again, to vote on these, you can just press the circle next to the option that you'd like to choose. And I'll leave this open for about a minute. All right, I'm going to go ahead and close that poll and then share the results. So it looks like 69% yes, 2% no, and 29% don't know or unsure.
Our work has been published. So this is the citation. I have to say, I'm very excited to see the poll results. I almost thought that 69%, the majority would say it's not practical. You guys were just lucky you had a grant to be able to do it, and you had committed partners. So it's encouraging. There are many innovations in APS practice that we could look forward to, and you have encouraged me a lot by that finding. Next slide, please. I'll turn it over back to Karen. Karen, for to monitor questions and answers. We wanted to make sure we had enough time so that we could take your questions. So I'll turn it over.
Yes, and thank you so much to all of our presenters today. This was wonderful. We do have a few questions that came in during the presentation, and for folks on the line, attendees, please feel free as we're going through them. If you've thought of any questions at the end of the presentation, feel free to enter those into that questions box. So the first question, I believe this came in, Farida, when you were speaking earlier, is how did you determine that 289 patients were reported to APS for the first time?
So we determined that when we looked at the data that Ray and Annette, our two APS specialists, gathered for us, and they had a column was if there was a prior history on this client. So the good part was that APS specialists had access to the APS database, which we wouldn't have known, we wouldn't have been. So if a person had a prior history, they would mark it as a yes in that column. And if the person didn't have a prior history, it was a no. So that's how we came to know that through the APS specialists going back and checking with APS records.
Great, thank
Does
you.
that answer your question? Does it
Yes.
answer the question? Okay.
Yes, that's great, thank you. And the next question, did the hospital and APS have to have an MOU to share information? So a memorandum of understanding.
I'll turn that over to Debbie and to Catherine to talk about.
Well, this is Catherine. We did indeed. We had to have a co-location and data sharing agreement because we had agreed to, they were agreeing to have a space for our APS specialist to reside in and do his work. And, you know, we had to take care of the technology, and we absolutely had to work on how can we share data. I think we both had some challenges in getting through our legal structures to get authorization to obtain healthcare information so Ray could have access to that, and so that Ray could freely share information and we could provide data to the study. So absolutely, that was a big piece of our agreement.
Great, thank you. The next question is, how were the APS specialists compensated? Was it through APS funds and WellMed funds, or one or the other?
So initially,
I'll handle that one as well. Debbie, do you
Sure.
want to, or I can?
So basically the compensation for the two
Okay,
APS.
I'll take that. So the project period you're talking about.
Catherine, we can't hear
This is a
you.
grant project, and so the funding came from a grant, passed through APS, and we gave the funds to WellMed. Isn't that right?
Yes, the grant funds paid for the APS.
Can you hear me now?
Salary.
Yes. Go ahead, Debbie.
What I was going to say is that the grant funds paid for the APS specialist salaries during the period of the grant. And then we were, luckily we were able to continue that with the second grant that we received. But now we have a contract with the state agency, and WellMed is paying for the salary for the APS specialist that's assigned to WellMed.
Great, thank you.
I don't know if you can hear me, but Debbie, I'm sorry I couldn't fill in. I guess I had a bad connection.
We can hear you now. Thank you all for bearing with us in technology challenges. Moving on to the next question. Someone asked, how many different healthcare agencies, hospitals, or providers would APS be expected to embed with in order to be effective?
That's a tough question. Is that in terms of whether you can be effective? We worked with just WellMed, but WellMed is a large system, and they have primary care clinics across multiple regions of Texas and Florida. Our study was focused only on Texas. I think you can even start small. You don't have to, you don't have to go and try to please the world and have a whole lot of healthcare systems sign up. Even if you worked with just one clinic, one system, or one clinic, I think it's a starting point. It's raising awareness of healthcare staff and clinicians about what APS does and can do, and what the two of you together can do to improve the overall quality of life of an older or a disabled patient.
Great, thank you, Farida. The next question is related specifically to the Texas APS program. The question is, does Texas have an adult service intake program? If so, was it considered to send the brothers through that supportive program rather than through APS?
I'm not sure what that means, an intake program that would be separate from APS.
I don't think so.
Okay, thank you.
I'm not really sure on what that means either, so I guess we don't.
Okay, thank you. And then there was another question, Ray, that came in for you. And the question is, did you use grants to repair the client's home?
No, we were actually able to, we used, like I mentioned, what we have is our purchase client service funds through the state. We used that, and then we also engaged other community partners as far as like Habitat for Humanity, that type of thing, to get what was needed accomplished.
Great, thank you.
Okay.
Another question, which I think would also be for you, Ray. Have you had any situations where the client needed guardianship?
Yes, yes, most definitely. And that's where I believe that this collaboration has been a great success from the standpoint of, you know, and you caseworkers out there know what I'm talking about. When you are trying to, one of the hardest things in the world is to get a hold of a doctor, to get a hold of medical records, get, you know, any information, and to be able to, you know, freely go contact someone, say, this is what I need. Not only does it save time for you, but, you know, also it could be critical for the client themselves. And so, you know, with the guardianships and trying to get mental assessments, and like Farida had mentioned earlier, you know, there were glitches on trust. Debbie can attest to this, that some of the clinics, doctors didn't feel comfortable providing, you know, a capacity statement of some kind. And so we had meetings about that. And it's just been little by little, you know, chipping away at these things. But yes, we did deal with guardianships during the grant, which were, by the way, successful.
Great, thank you. The next question is, how did the healthcare team document the collaborative efforts, i.e. their participation in multidisciplinary team meetings and their knowledge of APS involvement?
Debbie, do you want to
for
take
me?
that?
Oh, okay.
So what was the first part? That how do they document it? Or?
Yeah, absolutely. So it's, how did the healthcare team document the collaborative efforts, i.e. their participation in multidisciplinary team meetings and knowledge of APS involvement?
So
would that not be through like their medical notes, Debbie? That, you know, they document within the case, and the medical notes, because like sometimes I'll call a clinic and I may never have spoken to this individual before, and they pull up the medical notes for that patient and they say, oh, well, I see where APS was consulted on August 18th, and we go back and what was discussed between the two and what the game plan was going to be.
Yeah, absolutely. We utilize that.
The medical note. Yes.
And during the TCC meetings, all the staff have, you know, their laptops open, and, you know, patients go one by one, and there's a plan developed for each patient, which is documented in the medical record.
Yes.
Wonderful, thank you. The next question, did you determine how many APS specialists would need to be within a medical setting in order to meet the needs of that medical setting and the patient?
Debbie, do you want to take that?
Initially we had 2 APS specialists, and to be honest, I mean, Ray is by himself, and we are a large medical practice that has grown exponentially over the last few years. So Ray is a very busy guy. He and Ray can probably speak to this, but I don't believe that we ever did any sort of a time study or anything that would say, for X number of clinics, you need this many APS specialists. We have just, Ray responds as he can to all the inquiries that he gets. And, we, of course, our staff take on a lot of the referrals as well through our care management program. And then, the collaboration with the APS specialist. So I would say, no, we don't have a determination on how many people that you would need, but I think it works well having Ray available since he plays largely a coordination role. And I'll let you address that if you want to add something, Ray.
Well, I think, ideally it would be great if there were 2, but and as time has evolved, I think with this collaboration is that like initially before WellMed grew to such an extent, I was attending every PCC meeting and going around, but as they grew, it started, and either by phone or in person, and then as it grew, we wound up doing it on as a call as needed. So rather than me going and spending an hour and a half in a meeting at a clinic, they pardon me, both figure out which clinic that they're having an issue, they'll have me call in, and I am on the phone for like 5 minutes. So that's been able, good to help me budget my time. And like I said, most of it's through, or as Debbie stated, through emails and telephone calls on both sides, APS and with WellMed.
Debbie, let me ask you a question. If you had the other APS specialists there, do you think that you could fill her time up and Ray's time? I think that might help the person who asked the question.
Oh, I think so, definitely. I think, having 2 would definitely be better than 1, but unfortunately, we weren't able to retain the other specialist in the project ongoing. So
just as an FYI, the other person really missed APS practice and went back to APS. She loved her work at the healthcare system, but when the grant ended, she went back to APS and then got busy there and didn't come back. So we at least have Ray. Yeah.
Great, thank you all. Ray, there was a question that came in as a follow-up related to guardianship situations, and I think you started to delve into this, but just in case there's some more information you'd like to add to address the question, I wanted to read it out for you. The question is, if guardianship was needed due to cognitive impairment, how did you acquire proof of incapacity to make appropriate decisions for themselves?
In Texas, we have to go to the physician or a medical professional to ask if that individual does have capacity. And so usually it was through, just going and contacting the doctor, asking to have an appointment set up, make sure that the patient/client did make it to that appointment, and have them assessed. If the doctor, for whatever reason, didn't feel comfortable doing so, WellMed had some doctors that did feel comfortable doing so, so they might send that doctor over to that other clinic to do the assessment for us. And also what we've been doing a lot lately, actually, especially, is that the doctors have been making referrals for a neuropsych eval. And we just make sure that that patient gets to that appointment, and then we were able to determine capacity on that person. I think, does that answer?
Yeah, great. Yeah, thank you.
Oh, okay, okay.
And then we have one more question. So with states facing budget constraints due to the pandemic, do you think organizations such as WellMed are more open to partnerships that will include funding APS positions?
Harold,
I
do you
hope
want
so.
to speak from a healthcare perspective?
So yeah, so let me just say this. I think, yes, I recognize that states are impacted by the pandemic, but healthcare is also impacted by the pandemic. So I would think that until things are stabilized, and I hope that's going to be sometime soon, I think it would be difficult to have this conversation. There's just too many other competing priorities right now. So if you're asking, could this type of arrangement be a safety net for acquiring additional APS workers to address the issues at this point, I think it would be difficult to have that kind of arrangement negotiated because everybody's hurting from the pandemic.
But with the pandemic in mind, I think that because of this type of situation, this collaboration, that it's been successful because having both, a lot of times when you receive a case on an individual, you're, looking at it only from your point of view, and to be able to have like other sets of eyes on that individual, I think for the safety of the patient/client, I think that it's been very beneficial in a time of crisis like this. I don't know.
Great, thank you so much. And it looks like we have met our time. So I would like to say thank you so much to all of our presenters today for your work and for sharing this information and your expertise with us. And thank you to everyone who attended here with us today. You have a great rest of your afternoon.